Welcome to This Explainer. Look, today we're going to do something incredibly practical. We're taking those dense, complex medical guidelines and totally transforming them into a highly actionable master algorithm for managing heart failure. If you've ever felt completely overwhelmed by the sheer volume of data on cardiovascular care, well, you're definitely in the right place. We're going to focus purely on the clinical management, the specific sequential steps you absolutely need to take to stabilize, treat, and really optimize your patients.
Okay, so here's our roadmap for this structured clinical protocol. We'll be covering 1. Acute emergencies, 2. Lifestyle measures, 3. Pharmacotherapy, 4. Arrhythmia control, and finally, 5. Advanced therapies. Let's dive right in.
Step 1. Acute emergencies, specifically focusing on managing acute pulmonary edema.
When you're dealing with acute pulmonary edema, you are facing a life-threatening crisis. There is literally no time to second-guess yourself here. You have to execute this protocol immediately. First thing, sit the patient up. Second, get them on high-flow oxygen or use CPAP at 5 to 10 millimeters of mercury if they're in severe respiratory distress. Third, you want to administer nitrates. You'll titrate IV GTN upward every 10 minutes. But, and this is crucial, you must watch their blood pressure like a hawk. Stop immediately if that systolic pressure drops below 110. And finally, push an IV Luke diuretic, like 50 to 100 milligrams of furosemide, to rapidly combat that fluid overload.
Now, thinking about those steps brilliantly illustrates the why behind the emergency protocol. We aren't just blindly memorizing a list of actions, right? We're mapping exactly how your physical interventions directly alter the physiological workload of that failing heart. Just sitting the patient up immediately reduces preload. Adding CPAP drops that preload even further, along with the pulmonary capillary hydraulic gradient. Nitrates, they tackle both preload and afterload simultaneously, really taking the pressure off the pump. And of course, the loop diuretics step in to clear out that excess volume. Every single action you take has a very precise mechanical purpose.
Moving on to Step 2. Lifestyle measures. These are your baseline non-pharmacological interventions.
So, once your patient is finally stabilized and sitting in your clinic, you have got to establish these baseline interventions. If you don't, your medications are basically fighting a losing battle. You know what the most actionable tool is that you can give a heart failure patient? A simple bathroom scale. Seriously, daily weighing is an incredibly effective, completely non-invasive proxy for monitoring dangerous fluid retention. If you see a sudden spike in weight, that means fluid is pooling way before you'd ever notice peripheral edema. Couple that daily habit with avoiding high-salt foods to stop the fluid retention from happening in the first place. Oh, and absolutely make sure they're up to date on their influenza and pneumococcal vaccinations. A simple respiratory infection can so easily tip a fully compensated patient right back into acute failure.
Step 3. Pharmacotherapy, and how we handle the stepwise drug escalation.
All right, here's where we get into the real heavy lifting of chronic management. It is absolutely vital that you understand the functional difference between these drug classes. On one side, you have your symptom-relieving diuretics. These reduce preload and ease all that congestion, but they require super careful titration. If you overdo it, volume depletion can trigger acute renal failure. Now on the flip side, you have your survival-enhancing neurohumoral blockers. These guys don't just treat symptoms, they fundamentally alter the disease course by interrupting the renin-angiotensin-aldosterone system and stopping that toxic sympathetic overstimulation.
ACE inhibitors are really the absolute cornerstone of this whole management strategy. By stopping the conversion of angiotensin 1 into angiotensin 2, they shut down potent vasoconstriction and stop the kidneys from aggressively hoarding salt and water. For the patient, this translates to massive improvements in their effort tolerance and, most importantly, their overall mortality. But quick word of caution here. You have to actively monitor these patients for postural hypotension and renal impairment, especially your elderly patients, that can be incredibly sensitive to these central hemodynamic shifts.
Okay, listen up, because this is a major safety warning. It's actually a bit of a clinical paradox. We know beta blockers are incredible for long-term survival because they stop that damaging sympathetic overstimulation. But they are initially negatively inotropic. What does that mean for you? It means if you just start a patient on a standard dose, it can, and very likely will, precipitate acute on chronic heart failure. You have to start low, go slow, and up-titrate only as the patient tolerates it. Otherwise, you're throwing them right back into a decompensated state.
You're going to want to keep this dosing concept top of mind. Take bisoprolol, for example. You start at just 1.25 milligrams daily, with the ultimate goal of inching up to 10 milligrams daily over the course of several weeks. It is this exact evidence-based titration from these very specific, tiny starting doses up to the final target doses that actually secure us the clinical benefits. That includes a massive 33% relative risk reduction in mortality that we see with beta blockers. So remember, don't just start the drug, you have to plan the long-term titration.
Step 4. Arrhythmia control, where we manage the electrical complications.
As the heart muscle remodels and dilates over time, dangerous arrhythmias often start popping up, and there is a really stark contrast in how we utilize these two classic medications to deal with them. Digoxin, which is actually derived from the foxglove plant, surprisingly enough, is an absolute workhorse for rate control when heart failure is complicated by atrial fibrillation. It definitely keeps patients out of the hospital, but it offers zero long-term survival benefit. Amiodarone, on the other hand, is a very potent antiarrhythmic that barely suppresses the heart's pumping strength. But it is held strictly in reserve for exhausting, highly symptomatic cases. You never, ever use it for prophylaxis.
Finally, Step 5, advanced therapies. This is what we do when maximum medical therapy fails.
When pills aren't enough, these device escalations physically and mechanically reinforce the heart. For patients who are constantly plagued by dangerous ventricular arrhythmias, implantable cardiac defibrillators, or ICDs, are definitively proven to improve survival. Then you have patients with uncoordinated ventricular contractions, meaning the left and right sides of their heart are just totally out of sync. For them, cardiac resynchronization therapy uses highly targeted biventricular pacing to coordinate that squeeze, which significantly improves their overall cardiac output. And of course, if there's inadequate blood supply causing what we call hibernating myocardium, revascularization through a CABG or PCI can literally wake that dormant heart muscle right back up.
Now, when devices still aren't enough, we start looking toward cardiac transplantation. But let's be real, this is generally reserved only for younger patients who are experiencing severe symptoms despite being on absolutely optimal therapy. It remains a highly restricted absolute final option. That's mostly due to extreme donor limitations, but also strict contraindications, like severe pulmonary vascular disease, which would basically cause a brand new donor right ventricle to fail almost immediately.
So for those who are either awaiting a transplant or just in need of some short-term restoration, we turn to ventricular assist devices, or VADs. These pumps represent the ultimate mechanical bridge. They physically step in to unload the ventricles and pump the blood on behalf of the failing heart. However, it's not a perfect fix. Their use is heavily limited by some pretty extreme complication rates. You're constantly battling the risks of severe hemorrhage, systemic embolism, and deep infections. It is truly a high-wire act of intensive clinical management.
So we've walked through the complete 5-step pathway, all the way from emergency preload reduction in the ER down to mechanical ventricular assistance. As you take this clinical algorithm back to your own practice, I really want you to ask yourself this one final question. Are you titrating carefully to secure long-term survival, or are you just treating the immediate symptoms in front of you? Truly mastering heart failure means you have to balance both. Keep this algorithm close, stick to the steps, and you'll be incredibly well equipped to optimize your patients' outcomes. Thanks so much for joining me on this explainer.